We're moving on to the next keynote address by Dr. Prathima Radhakrishnan on the topic Fetal Medicine, Redefining Future of Obstetrics. Dr. Prathima Radhakrishnan is the Director and Consultant at BFMC with 16 years in FM. Over to you, ma'am.
Okay. Thank you very much, and thank you, chairpersons, and a warm gratitude to Dr. Jaykrishnan, Dr. Nilanjana, Dr. Ashwin, and the entire team of Trivandrum OBG Club for giving me this honor to give a keynote on how we are going to hopefully see fetal medicine evolve and redefine obstetrics in the upcoming decade or two. Okay, so now this is where we are at the moment, and there is a big gap from the traditional obstetrics where the focus has been primarily on the mother, and where we are trying to shift is to a new reality where the fetus is seen as a distinct patient. And this has been largely possible because of this fantastic machine, the ultrasound machine, which has evolved so much in the last couple of decades. And we can see the fetus from as early as a month to, growing right up to 9 months. And each time it's a different vision that comes up as a reality. Okay, so this is where we are focusing now, of the fetus as a patient, and we have to change our concept from just the mother to two patients, that is the fetus and the mother. And of course, we want to make sure that when we are looking after the pregnancy, that the interests of the mother and the fetus align, but sometimes it can be a bit of a balancing game. Now, I did speak about this early in the day about the vision of the 12-week scan, which is the early window of opportunity, and where we are shifting the pregnancy care from the beyond 20 weeks to early on to the 12 weeks 12-week point. And this is largely possible because of the paradigm shift in the antenatal care. We are going to screen for majority of the pregnancy related complications in the first trimester at the 12 to 13 week scan, and this is screening and diagnosis which has come into the first trimester. And now this inversion of pyramid of care has largely been possible because of the in humongous amount of work done by Professor Nicolaides, where we are detecting more and more problems or predicting more problems more accurately, so that we can take a proper step in order to reduce the complications for the mother and for the baby, right? So the first trimester scan is going to alter your trajectory of the pregnancy care. Now, coming to advanced diagnostics, now NIPT is, the most recent advance that we have seen, so widely used. Of course, it's safe, it's a blood test, and you can start doing it from 10 weeks onwards, and it has got a 99% accuracy for Down syndrome, because it was a test that was designed for Down syndrome, and of course it also checks a few other chromosomes. However, we must remember that it's a screening test only, and as we are applying it more and more in the clinical scenario, we are learning many more new lessons as well. So if you have a high-risk NIPT, you must do an invasive test, and there is, of course, this thing which we spoke about in the morning about NIPT versus the traditional screening, and of course there is variations in the labs. Now, what we are moving in the future is what we are going to probably see NIPT being used for doing a whole exome sequencing from the maternal blood itself for rare genetic syndromes. This is the work which is ongoing. Now, the other important condition is what they call as a liquid biopsy of the placenta, where the placenta secretes the cell-free DNA, cell-free NIPT is also detected from the cell-free DNA only. The cell-free DNA, cell-free RNA, the extracellular vesicles and cytotrophoblasts into the maternal circulation, and based upon how many of this is present or how much of it is present in the maternal blood, it would be possible to predict the possibility of developing preeclampsia, growth restriction, placenta accreta syndrome, preterm birth, etc. And of course, this is non-invasive for the fetus with no additional maternal fetal risks. And of course, there is a real-time dynamic monitoring as well for these. Now, as I said, it predicts maternal complications. However, there is a cost attached to it. It will come with a cost. There will be an accessibility challenge, and of course, the standardization will be required. But continued innovation and is very, very important. And how we are going to apply it in an equitable implementation kind of a scenario is something that will come subsequent to the adoption of these policies. The next big one is a really high resolution imaging with AI assistance. So as one is performing the scan, the AI is interpreting in the background, creating a biometry as well, taking the measurements and defining the structure of the fetus. Now, this happens in real time, and it's already happening in a few clinics, but largely in the research setting only, because we still need to define how much of abnormals the AI will be able to pick up. But it has already been shown that with the AI-driven AI assistance in fetal ultrasound, it is possible to reduce quite significantly the scanning time, right, for more than 6 minutes reduction, which makes a big difference in the whole clinic, of course. And very importantly, also the human errors that is possible when we are not very good in scanning. And if the AI can pick up a few things and highlight a few things, this will be really, really good. So speed, efficiency is also very important. Now, lots and lots of studies. This is just 2026. So many studies on the Google search, and then all these, on a daily basis, we are seeing more and more studies in the AI field itself, which is looking at automated biometry. A part of it is already available. It helps in better dating. It helps in early fetal growth restriction detection, which is a big challenge in fetal medicine and obstetrics at the moment. Improved fetal weight estimation and improved detection of anomalies, and this is probably what you will be seeing in the upcoming years. Now, the other very important thing is POCUS. POCUS is point of care of ultrasound. Now, it has been largely used in emergency medicine, where it identifies specifically what you want to see. So if you want to see the blood flow in the carotid artery, for example. So it just measures that much. So it is not a replacement for the entire ultrasound. Now, this is a practice guideline, POCUS, released by the International Society. Even in OBG, it's being used. And what they have found that and recommended is basically in the first trimester, it can be used to assess whether it's an intrauterine pregnancy and its viability, to confirm the fetal presentation, and of course in non-pregnant patients presenting with symptoms of abdominal pain and bleeding. So in these, it has been shown to be beneficial, whereas the others are still work in progress, right? So POCUS is something which we need to look out for, and it does not apparently does not require a lot of clinical expertise. Now, moving to another area which is, very, very becoming more and more advanced is fetal MRI. 2D MRI, 2D we are using already, the 3D and the AI enhanced MRI. However, we need fast sequences for this because of the presence of the fetal movements, and it is used, we know fetal MRI is used when ultrasound is equivocal, because largely we can see a lot of things from high-end, high-resolution ultrasound, but sometimes we need the backup of MRI as well. So it's preferred to be used after 20 weeks, and certain times when ultrasound is difficult, it's not, it's impossible to see it, then MRI would be helpful. And very importantly, when we use AI, it's very important to ask a question. We have to be very specific what we want to see. For example, if I have to differentiate between CPAM and congenital diaphragmatic hernia or congenital diaphragmatic eventration, that is a question that I ask the MRI and say, differentiate this for me. Otherwise, to reconfirm your scans, it's of not much added benefit. Of course, there are limitations that it's not available everywhere. And to read a fetal MRI also, you need somebody who's really good to read the fetal MRI, because fetal MRI is not just the same as adult MRI. Now, the genetic revolution, and it can be so confusing, as we all know. We are already seeing part of it, but what can happen further? Apart from the NIPT revolution, we have shifted beyond karyotype to array, but from array we have now moved into whole exome sequencing, where blood is, and of course in the prenatal setting, it is recommended that you do a trio exome, where you look at both the mother, father, and the fetus. So you take the blood from them, you put it into the sequencing or the NGS machine, and then it works out the genetic makeup, looking at the exons, and then gives a final diagnosis. But of course, in a situation like this, you may pick up things that you were not originally looking for at all, or you may pick up some other things. And that is why it becomes even more important in prenatal situation to do it as a trio, because if you do only the fetus, you may find certain genes that is not that is not explainable to the condition that you are looking for, particularly when the practice of doing whole exome on every marker. That's not a right practice, because we don't have enough information about the exome per se. So it is very important to do it as a trio along with the parents. Now, the other thing which is rapidly coming into the practice is carrier screening, where carrier screening is being offered by the laboratories. And of course, the laboratory medicine is much faster than clinical medicine, and the couples are choosing to do carrier screening even before they have their first child. Of course, there are pros and cons to it, and they check for any common genes in between the two parents, and then consider having a pregnancy. Now, from diagnosis to next thing is we are going to be moving into cure. I heard Professor Hull speak on the CRISPR technique. Now, CRISPR gene editing tools also being used in gene therapy, in fetal medicine as well, where CRISPR is used to edit the gene, and of course the embryo replacement therapy mechanisms as well, and I will come to it in a minute. So coming to the section area of fetal therapy. Now, fetal therapy we know could be medical therapy or surgical therapy, and one of the classical examples is maternal steroids for fetal maturity, with every obstetrician does fetal therapy. And of course, apart from that, there are many other conditions where you would give the fetus therapy through the mother for heart blocks, and then ultrasound guided fetal therapy for pleural effusion, pleural drainage, and pleural shunts, intrauterine transfusions, fetal reductions, and fetal laser therapy. So ultrasound guided fetal interventions are available. I wouldn't say widely available, but yes, available, and it is possible to be further innovations is possible to reduce so many other challenges that we face with these procedures as well. And then what is already reasonably well established in India is the fetoscopic laser ablation for complicated monochorionic twins. What is still not, to my knowledge, has not been done is a feto for diaphragmatic hernia and surgery for spina bifida. which could be a laparoscopy assisted or a mini laparotomy. This is from my friend Fabio Peralta in Brazil, where they perform many of these surgeries for fetal spina bifida in utero itself. Okay, so coming to in utero gene therapy, now there was a big hemoglobin breakthrough for which Professor Stuart Orkin was given the Breakthrough Prize award as well. So CRISPR-based treatment is one of the first treatments that has been approved for sickle cell disease and beta thalassemia, where the BCL11A gene, which is responsible for stopping the fetal hemoglobin, is actually blocked so that there can be more fetal hemoglobin, and this way they can actually treat beta thalassemia or remove the insults of beta thalassemia and sickle cell disease. And this is one of the first treatment, gene therapy, that has been approved by the FDA as well. Now, what about AI and big data in fetal monitoring? Now, there predictive analysis using AI has been there, and for example, you can predict CTG analysis on a continuous basis, and this can help to assess the chances of fetal hypoxia and in fact even reduce the cesarean section rates. Currently, what we are using AI is to standardized fetal ultrasound practice. That is where I am involved, certifications, helping in screening, helping in diagnosis, and it possibly can help aid therapy by robotics as well, and even remote monitoring of the fetus. Now, fetal medicine should be evolving largely as preventive medicine. Now, we know, we are all aware of the Barker hypothesis, where the adult diseases, particularly coronary artery disease and all, starts in utero by in utero insults to the fetus. So it goes back down. And what happens is the further thrifty phenotype, where the mismatch happens in the first couple of years after life, where suddenly from starvation, the baby goes to enhanced environment, and because of that also there is a adjustment problems, and what they say, fetal programming loads the gun, and actually the mismatch pulls off the trigger. So rapid catch-up growth can increase further the risk of congenital heart disease. Now, so what? We have so many big things coming. How can we shift, make it more equitable? Now, we live in a very heterogeneous population. We are in a, we have very high-end private sectors where the focus is on precision and women's choices. And we are doing high-end genomics. We consider fetal MRI. There is bespoke birthing experiences, and training, everything is happening. So of course we have one end of the spectrum, and the other end of the spectrum where we have the government sector, where even proper screening is not available, and where we are struggling to bring in better, prevent and help. Prevention and survival seems to be the focus in these situations. So what is it that we can do to bridge this gap? Now, it is possible with the current technologies that is available, and which will evolve even better, to have a focused fetal medicine specialist in the middle with the spoke and the wheel, the spoke and the model, where you have the fetal medicine specialist in the center, and you have the nurse who might be doing the point of care diagnostics at a distant place, and transmits the images to the radiologist or the fetal medicine specialist who's sitting in a central area reading all this. And this is possible through portable ultrasound machines and handheld. I don't know whenever we are going to have portable ultrasound machines, but this would be very useful, particularly in the rural sections of our country. Now, the other very important aspect I can see is, even as we are scanning, the AI is calculating the proper views and assessing the views and the correctability, and this way we can actually train more and more people to do better quality ultrasounds as well. So, and finally, the public-private partnership tie-ups, and I know I've been very fortunate that I could manage to do this very recently after a 12-year struggle to tie up with the government sector and provide the fetal care there, and of course the genetics laboratory has also come in with much reduced costs of the care as well. So this bridge is extremely important. Now, coming to the economic factor, now what is the ROI that we get? Now, we must remember when we compare the importance of screening, we have to compare it what if we don't screen and that problem is there, and that cost effect is huge. You take simple things like for preeclampsia 500 rupees for a low dose aspirin, whereas if the mother develops preeclampsia and lands up in the ICU, that is going to be significantly high. TTTS surgery, we complain it's not 3 to 4 lakhs, it's about lakh and a half. But if there's no treatment and there is severe preterm delivery, then that cost is many times higher. So we need to weigh the balance against what if we don't do, what will happen to that pregnancy, rather than just use the same pain. So to summarize, every technological leap brings in more questions, and we are moving from a world where we were accepting everything that was given to us, but now we are seeing more and more parents who want to choose what they want to do. And it is only right that we intervene with choice. We have a right to choose. Now, just like how there are visions for the 100 years of 2047, where we are going to be a century, I think we need to have a vision. We need to have a vision that the children that are being born today are going to be the leaders of tomorrow. And therefore, if we ignore their health in their womb, that is going to obviously reflect how they will grow up as adults. So we need to redefine obstetrics and prenatal care, and also at the same time work towards not making it only a luxury for the rich, but also a standard of care for every Indian mother. So that brings us to the 1,000 days, where the first 270 days of the pregnancy followed by the first year and the second year, which is so very important for the development of this baby. So obstetrics has to continue up to 2 years also, but also it has to go hand in hand with fetal medicine. And it has to be a mantra that we don't deliver at all costs, but we deliver with and give the baby or the fetus the best possible start. So with that, I conclude my talk. Thank you very much.